Hello, welcome and kumusta, and thank you for joining me today. My name is How. I am your occupational therapist. In this episode, we will try and understand the motor behaviors. That's right, we're going to talk about motor behaviors because I understand that stroke, for particularly, or neurological impairment, this is one of those very specialized area that most occupational therapists want to learn about. So, any symptoms or any way to understand motor behaviors and neurology and stroke and spinal cord injury or head injury. So, this is something that is very enticing to a lot of people. In this episode, we will talk about motor behaviors. Particularly, we will look at some of the parts. We will be discussing some of the parts that can affect movement. And then we will be describing the movement problems that are caused by some of the different parts. Now, when we are talking about movement disorders or the person is moving in a funny way, there are just, from my experience, there are just three general categories that will have an effect on the movement, or there are three major parts of the brain that has particular characteristics. Okay, particularly this is the cerebral cortex. So you can have problems with a basal ganglia, and then the other one is a movement that is characterized particularly cerebellar in nature. So these are the three major area. So movement problems, because there is a problem with the cerebral cortex, particularly with stroke, for example. So you would have that, or head injury. Yeah, that's way very obvious. Another one is a cerebellum, which is at the back, which is a very, very small part, which is at the posterior part of the brain. Okay, and that will have something to do with coordination. And then another one is the basal ganglia, which lies underneath the cerebral cortex. Now, there will be some problems with these parts, the cerebellum, basal ganglia, and cerebral cortex, on situations and on conditions that a person has had some stroke. Yeah, because stroke is technically a there is a lack of blood supply in the brain, so the brain did not receive the appropriate blood supply, and these blood supply, it can vary. There are some blood that supplies the cerebral cortex, then you would have some impairment there. But there are some very, very minute blood supply, which is particularly, it branches out from the cerebral artery, and these are the blood supply, the medial striate arteries, for example, that branches out from the medial cerebral artery, uh, and it supplies the internal capsule. It supplies the basal ganglia as well. So the lateral striate arteries, and you have the middle striate arteries. So if you have a stroke, then that can be affected, but it's very, very tiny. So very, very tiny. It's usually a problem, more of a problem post surgery. And then another one, where you can have a blood supply that supplies the cerebellum. And in here, you have the vertebral artery that's supplying it. You have the posterior inferior cerebellar artery. You can have the superior cerebellar artery. So there are plenty of arteries that are very, very significant. Now, on very rare occasions, you would have spinal cord stroke, so spinal stroke. And this is because there are some blood supplies that is coming from the aorta, and it is it's the vertebral artery. You can have the basilar artery, ascending cervical artery, thyrocervical trunk of the aorta, for example. and you can have the radiculomedullary arteries as well. So there's plenty of that. So those are the blood supplies. So really, what I'm saying is blood supplies, once there is an interruption or there's a problem with blood supply, if it reaches the major parts of the brain, then you will have some movement problems. Again, what I said, you have problems where there are cortical lesions, which is the cerebral cortex, then you have the cerebellar lesions, and then you have lesions in the basal ganglia. Now we'll talk about some of the movement disorders on those particular areas. So this time, let's talk about the cortical lesions. So if you've had a stroke, particularly with stroke, so the the cerebrum, cerebral cortex, that's why it's cortex, yeah? Cerebral cortex is impaired and the blood did not reach the cerebral cortex. And once this happens, you would have some movement problems that will be very, very obvious. So, one is the problem called the person is likely to have some hemiplegic posture. Hemi meaning half, plegic meaning paralyzed. So, half of the body will be paralyzed. So when half of the body is paralyzed, how does that work? So one side is definitely weak, and then the arm can either assume a flexion pattern or an extension pattern. So let me see if I can describe this correctly. So the elbow would be bent, the arm would be in internal rotation, the wrist and the fingers can be bent, and it could be tucked in. So the arm can be adducted, internally rotated. So technically, the arm is really tucked into the chest. So that is a particular hemiplegic posturing, okay, particularly if there is a strong spasticity in there. So you would have hemiplegic posturing. Because one side is weaker, then it's lopsided, isn't it? When somebody is sitting down, the position is lopsided, and then the leg is actually, it doesn't have a right tone as well, so it can either be on external rotation on the hip, can be very weak, or if it's or it can be internally rotated if the internal rotators are there, spasticity on the hip adduction as well. So that can be a problem on that. Hemiplegic posturing is one. So hypotonia is one of the symptoms that assumes that that there is a problem with the cerebral cortex. Hypo being less, tonia is tone is very low, so you just have low tone. Okay. Now the opposite of hypotonia is hypertonia, yeah, where it means that the tone is more than usual. Okay. The normotonic, that's what we want. Normal being normal, and tonic is normal tone. So, on a day to day situation where there are no problems, the natural state of the muscle is called normotonic, or it's in normotonia. All right. So, when you have a problem with the cerebral cortex, you would have either hypotonia or you can have hypertonia. Another symptom of a cortical stroke, for example, is a symptom that is called spasticity. And this is there is an increased resistance appreciated by the examiner when the joint is moved briskly. So you can tell that something is spastic if you do a quick stretch, you straighten or you bend a joint, for example. Particularly, it's very obvious on the elbow. So if the elbow, the starting positions, the elbow is bent, and you quickly stretch the elbow to straighten, you will feel a catch, and it depends on where. Sometimes if it's mild spasticity, the catch would be at the very end, or if it's a moderate spasticity, it's somewhere in the middle, and then severe spasticity is like as soon as you move it, it just pulls it back. So spasticity by definition is an increased tone in response to speed. Okay, so that is that spasticity. Another symptom that you would notice is the symptom called clonus. And clonus is an oscillating contraction and relaxation of the limb segment due to the alternating pattern of stretch reflex and the inverse stretch reflex of a spastic muscle as well. Now, the clonus is particularly visible and it's easily observable on the wrist. So it's a wrist clonus. How do you do that? And what you do is you quickly extend the wrist and you keep on pushing that. Keep the wrist in an extended position. Keep applying that pressure. And when you do that, you will notice that the wrist would bounce forward and back. Yeah. And why that is happening is there is the flexors of the fingers and the wrist is being stretched because you're really stretching it. What it's behaving like a patellar reflex, like a knee jerk, so it just keeps on bouncing forward and back. The wrist would just be bouncing. So that's clonus. It's called the wrist clonus. You can also do this on the ankle. And how you do this is normally the ankle of a person with hemiplegic posturing is the ankle would be in uh, its plantar flexion. So what you do is you quickly move the ankle into dorsiflexion and you keep that pressure, keep that movement into dorsiflexion. And what you would notice is that the ankle would be moving forward and back. So there's an oscillating movement there, as if the person is doing some sewing, like the old school sewing machine. For those of you who are young, you probably have not encountered this, but for those people who remembers their grandparents, it's like a sewing machine, and it just bounces up and down as well. So clonus is one of those cortical lesions. Now another one is the when somebody has had the spasticity, it's called the clasp knife phenomenon. So you know what a clasp knife is. Those clasp knife being like for example the Swiss Army knife, for example, or a pen knife. You move it to a certain point, and as soon as you reach a certain point, it just either closes quickly or it extends quickly. Just imagine of the arm, the elbow, like a Swiss Army knife. So as soon as you move it, when it reaches a certain point, if the starting position is on flexion, for example, and you start to move it, once it reaches a certain point, it just goes into extension. So that's an extension, like a clasp knife. Or you try and bend it if it reaches a certain point, and then it just goes back into flexion. So clasp knife phenomenon. You would observe this in spastic upper limb. Now, hemiplegic is hemi, Latin for half, plegic is paralyzed. Yeah. And when you have this, one of the hallmarks or one of the symptoms of a cerebral stroke or cortical movement disorder is a weakness, yeah, which is the inability to generate the necessary force to achieve or demonstrate motor function. Okay, so weakness, and this is because the muscles are technically strong, but because the command is coming from the cortex, then the muscle would just not generate the amount of energy. But the muscle bulk is there. Over a period of time, if the muscle hasn't moved, then definitely the person would be weak because of muscle wasting. And another one is called the loss of fractionation. And this is the inability to move a single joint without producing unnecessary movements in other joints. So this results in stereotype movement patterns instead of selective and flexible movement patterns. So remember that. That's a big word, loss of fractionation. Another one that is a problem with movement, a cortical problem, is a problem called apraxia. And apraxia is the inability to perform purposeful movement in the absence of weakness, in the absence of ataxia, in the absence of sensory loss, or abnormal muscle tone. So, the person cannot perform purposeful movements despite everything being normal. So, praxia, purposeful movement. And this is because it's almost like a cognitive motor impairment. It's not because they're not weak, but they just couldn't perform it because the brain, which is the cortex, the cortical part of the brain, is the one that is allowing the person to willfully move their arm. Okay. Another type of problem is a problem called lead pipe rigidity. So you would have this, and this is characterized by a hypertonicity of, of both the agonist and the antagonist muscles. So rigidity, the arm is stiff and it will assume one position and in one posture, whether it's both tucked in, like a wing tucked in, and if you pull the arm into extension, you cannot pull it. But once you pull it into extension, you push it and it just won't do that again. So this is called a lead pipe rigidity. So rigidity is one of the movement problem of cortical movement disorder. Now let's go to the second part of the brain, which is the cerebellar dysfunction. So we have cerebellar dysfunction. And when you have this cerebellum or cerebellar impairment, cerebellar dysfunction, so movement disorders caused by problems with cerebellum, you would have symptoms like intention tremor. And this is a tremor that usually increases as the goal is approached. So at rest, the person is not moving or you don't observe any shakes. But as soon as you get the person to reach for something at the end range, it just shakes. Yeah. So this is where they wanted to see is it past pointing. So intention tremor. Yeah. And you also have overshooting. Yeah. And this is the inability, so overshooting or dysmetria. This is difficulty. Metria is meter or measuring. So difficulty with the measurement of movement, meaning when the person reaches for something, it just overshoots. And this is the dysmetria is the inability to direct or limit the motions properly, and it is again characterized by overshooting. Another symptom is called dyssynergia, or there is a decomposition of movement. And this is characterized by movement that are broken up into their small component parts rather than being a smooth and coordinated movement. So this can be assessed on coordination tests such as the finger to nose test, okay? Another symptom is called dysdiadochokinesia. Whoa, that is a big word. This is difficulty. Is to doko is alternating, kinesia is movement. So this diadochokinesia is the inability, or adiadochokinesia is the inability to perform rapid and alternating movements. Yeah. So what you do is you ask the person to say if they're sitting down, you get the person on both their left and right arm an alternating movement of both flexion and extension. See if they can do that. Or an alternating movement of pronation supination. See if they can do that. Or you can get them to clap their hands, so put their hand on top of the other and get the other hand do a clapping motion, where the first movement would be palm to palm and then palm to the back of the palm to the back of the hand and palm to palm to the back of the hand. So you do that like a clapping motion, and you can see that the impairment is that the person has difficulty controlling movement on the other side. Okay. The other one is an ataxic gait. So when somebody is walking and you see that they are wide based, It is unsteady, staggering, with tendency to veer towards the side of the lesion. Yeah. So why is it towards the side of the lesion? So if somebody has had a cerebellar stroke and it's on the right side, they would veer on that side. Why? That is because in cerebellum, it is ipsilateral. Okay, it only becomes a contralateral problem if it is a cortical lesion, because it's before it reaches the nerves, before the nerves reaches the cerebellum, it crosses onto the thalamus. So, yeah, so that's one of the hallmark. So the problem is on the ipsilateral side, wide-based gait. The other problem that you would notice is that there is a decrease in muscle tone, because the uh, the the cerebellum has the inability to influence on the stretch reflex as well. So those are the symptoms of the cerebellar impairment. So why is it? So if you think about it, why is it that there is a coordination problem? Well, there is a coordination problem because the proprioceptors. So remember the proprioceptors, which goes at the back of the spinal cord, or spinal, yes, back of the spinal cord. They are the posterior, the dorsal pathway. It integrates onto the cerebellum. So this is where be the center for coordination. So the arm is generally strong. If you ask them to push on something, they sometimes can't do it. You ask them to move, they can't do it. You ask them, but if you push against the hands, then the arm would push hard against it, and you would think this is not weak. How come it they can't instigate the movement, but it's not weak? Is that's because when you push against the hand, you are providing proprioceptive facilitation on it. Yeah. Right. And the third and the last part is a problem with basal ganglia. And on basal ganglia impairments, you would have movement problems such as tremors at rest or resting tremor. So here, the tremors would stop at the initiation of movement, but as soon as the person stops moving, then this is where you would observe that the hand is shaking. So this definitely would have a fatiguing effect, and you need to instruct the patients to learn how to compensate and control it by stabilizing the arm on the armrest. So a typical problem with resting tremor, a typical condition would be that of Parkinson's disease, isn't it? So when people are at rest, you can see the arm shaking very, very violently. But when you ask them to do something, then they'll be able to do it. So resting tremor is a is a basal ganglia problem. Now, another thing is that the movement is very slow. Yeah, and this is a symptom called akinesia or bradykinesia. A is without, akinesia is without movement, or bradykinesia. So brady is slow, kinesia is movement. So, and this can be seen, people with lack of facial expression, for example, they have monotone voice, they have reduced eye movement, they have diminished swing during walking. And when you're slow to move and you're not swinging the arms, you have a decreased balance, and the equilibrium reactions are also very, very, very weak and very slow. And this is bradykinesia. Again, very typical of a Parkinsonian problem, isn't it? So while ataxic gait is the problem for cerebellum, which is wide based, in basal ganglia problem, you have a problem called festinating gait, and this is small, fast, shuffling steps that pushes and that propels the body forward at an increased pace. Again, very much of a hallmark of a Parkinson's disease. Okay, so those are the very popular ones. Now, every now and again, you would, and this I have observed in post surgery, and particularly if you've had heart operation and there is an incident in there. So it's a symptom where the movement is involuntary, slow, writhing movement. Yeah. And this is called athetosis. So you can see the fingers and the face that is slow writhing, very slow. Yeah. And yes, it's a symptom called athetosis. And yeah, you would observe this typically in cerebral palsy. Children with cerebral palsy as they grow up. So there's an athetoid type of cerebral palsy. You can see how they're moving. It's slow and writhing. Yeah. So that's one. The other problem there is a bigger one is rapid, jerky, irregular, and it primarily involves the face and the distal extremities. So the muscles can be hypertonic. The problems may happen during a sleep. Yeah, this is now called coriform movements. Yeah, coriform movements. And that's why, again, in Parkinson's, one of the questions is there a restless leg syndrome? Because it kicks even when the person is asleep. So that's rapid, jerky, irregular movements. It involves the distal extremities. You would observe this in the hands or in the face. It just happens. Coriform movement. Another movement problem is a form of athetosis. Do you remember the athetosis is a slow writhing movement? But this is a form of athetosis in which but there is an increased tone that causes distorted features or distorted postures on the trunk and the proximal extremities. So when the trunk moves forward, the person would just go bend forward, and once the person extends, it'll just go all the way in extension like a lordosis. So there's involuntary contractions. It results on torsion spasms. Torsion is like, yeah, it's pulling the muscles, and then it's spasmodic, torsion spasms, and there is an increase on lumbar lordosis. This is a symptom called dystonia. Another symptom is a unilateral, so just one side. Yeah, remember the coriform movements is just a tiny jerky movements, but this time it's a unilateral chorea where it is violent, forceful. The arms are flinging. There's flinging of extremities on the one side of the body. Yeah. This is a symptom called hemibalismus, and it is a problem where there's lesions in the subthalamic nucleus. All right. And one more is a problem where, do you remember in cortical lesion, you have a lead pipe rigidity? Now this time it's a cogwheel rigidity. So cogwheel meaning it's like the arm is just like a cogwheel. So there is like you pull and there is like stops in between, like a cogwheel. So that's the symptom called cogwheel rigidity. Right. So other movement problems that we have, and again, there are plenty of terminologies out there. You have blepharospasm, and this is intermittent contractions of the orbicularis oculi. What is the orbicularis oculi? It is the muscles that surrounds the eye. So it's like it shuts, the eyes are like shutting very tight, and it's like spasmodic. So blepharospasm. You can have the writer's or occupational cramp as well, and it's presenting with uncontrollably tight grip accompanied by flexion of the wrist, where there was jerking or there's a sustained movement are often associated with this. So that's called a writer's or occupational cramp. You have oromandibular dystonia, and this involves the muscles of the tongue, the mouth, the jaw, and it causes the mouth to pull open or forcibly shut. So the mentalis and the platysma muscles are also involved in here. And this is oromandibular dystonia. You can have a symptom called spasmodic torticollis. Torticollis is like a stiff neck. So, the neck is just spasmodic, and the person just turns the neck, you know, and it's like, I don't know how to describe it. I'm moving it, but I'm hoping that you guys would see it, while I'm talking about it. So it's just the neck is just twitching and causing the head to almost go on lateral flexion and rotation as well. But this is spasmodic, yeah. So that's called spasmodic torticollis. Again, very much of a no, very much of an internal capsule or basal ganglia problem. Okay. You would have hemifacial spasm. You can describe it like that. Half of the face is like spasmodic as well. You can have coprolalia, which is an involuntary use of obscenities and obscene gestures. So when you have obscene gestures, it's copropraxia. Copro is like obscene, isn't it? Coprolalia, lalia is you saying some obscene words, coprolalia. But when you're like, putting up the finger, uncontrollably, you have the copropraxia. You can also have some tic, yeah, tic douloureux. And again, these are all basal ganglia. Now, not everything is all to do with the basal ganglia. Sometimes some of the movement disorders are caused by a psychological impairment. Yeah, so problems with psychology. But most of the time I've seen people trying to blame it all to psychology, but you can't blame it to psychology straight away, isn't it? When there is an impairment and when there is an event, that would be the primary reason why the person would have some problems with their movements. Okay, so you have other symptoms called postural or static tremor. So this occurs with maintained posture. It is tested through holding the arms front out. And then you can have physiological tremor. You call it essential tremor or tremor of the basal ganglia disease, tremor of peripheral neuropathy or alcoholic tremor. These are all postural or static tremor. You also have kinetic or intentional tremor, and it occurs with movement from point to point. And it's tested with finger to nose test. And you have some task specific tremors, which occurs only with specific types of movement, like writing tremor or vocal tremor. Yeah. There you go, guys. Thank you for joining me. Again, in this session, we have spoken about some of the symptoms of movement disorder. So this is all about understanding some movement disorders, generally just by observing the patients and by knowing what the symptoms are. You'd be able to locate where the problem is. Somebody's had weakness, yes, stroke, cerebellum, there's no problem there. That's most likely what the situation is. Anecdotally, there was one situation where there's this one nurse who trusts my skill where I am working, and there's a person who's just had recently recovering from a surgery, and the nurse approached me and said, "There's something wrong with this person. Half of the body is just like moving." And as soon as I saw it, there is a corifor movement. So there's jerking movement on the arm. Is not too bad. And then I saw, oh well, that's a basal ganglia problem. It's very evident. And in passing, one of the intensivists and the consultant just went passing, and then The consultant wanted to check, is it really? Let's have a look. They've had the CT scan, and bang on, you know, the impairment was, lucky enough, it was, well, it's bad, but it was already established it was on the basal ganglia. So just by finding out or identifying these symptoms, you can tell which part of the brain is impaired. Okay, so I think the technique here is for you to be mindful of these movements, to observe what it is that you're seeing, because anything that you're seeing, it means there is something there. Yeah, and the chances of faking it is very slim. But sometimes the clinicians are very good in just blaming it all to psychology. So, thank you for joining me, guys. I hope you have learned a little something from this talk. And what I would like you to do is talk to each other, go out there, observe these movements, and once you have, just write down the symptoms and have a tick box. It's just like seeing. It's like bird watching, isn't it? So just go out there, observe, watch out for these symptoms, and if there are some strange symptoms that you are seeing, you need to escalate that or find a colleague who can help you with it. Okay, well, until next time, guys, just remember, anything you do matters and has an outcome. Until next time, bye.